welcome everyone. I'd like to thank you for joining us this afternoon. It's pretty exciting for me because we have Dr. José Esparza, a BCM alumnus who is the senior advisor to Gates Foundation, kicking off our Globalization lectureship. As you may recall, when I first got here, I identified as one of the highest priorities was to set up the Office for Globalization. 2/3 of our faculty already have significant relationships outside of our own country, and it was, I thought, imperative to begin to at least organize and understand what we were doing, and part of that whole initiative led, of course, to the recruitment of Peter Hotez. So it's been a fantastic, fast start to our globalization efforts. We couldn't have started it without a very generous gift from one of our trustees, Wally Wilson, who couldn't be here today. But Wally is a real visionary. He himself has an international company and has always been interested in the health affairs of everyone throughout the world. A very wonderful guy, and so we really are grateful to him. I'd also like to point out that we have some of our Board of Trustees members here. James Chow just walked in to say hello, and Gerald Haddock and Ali Saburian, showing that our board is also very involved with our global efforts. And I'd like to also acknowledge David Schultz from the Gates Foundation and some of the ExxonMobil occupational health team that has joined us here as well. Thank you for coming. The last thing I want to do is tell you a little bit about Bobby Kapur. We looked for a director for our Office of Globalization. Bobby has had extensive experience internationally. He runs the training program in the emergency department, and it was very easy to find somebody right here on campus who could lead us. And Bobby, thank you very much for taking on that responsibility, and I will turn over the introductions to you.
Thank you, Dr. Klopman. Thank you for your leadership of the college and for your support of the college's global activities and efforts. You've guided Baylor College of Medicine through remarkable achievements during the past year and a half, and we appreciate your leadership. To the members of the Board of Trustees, thank you for your stewardship during these momentous times, and we appreciate all the support you've provided all our global efforts moving forward. Baylor College of Medicine has a long legacy of enduring and meaningful relationships and transformations in the global arena. From Dr. DeBakey's pioneering advances in international diplomacy to the college's cutting-edge research in areas such as genetics and virology. From the Baylor International Pediatric AIDS Initiative in Africa and Eastern Europe to the launch of the country's first school of tropical medicine. From the college's community outreach through our college's shoulder-to-shoulder program in Central America to the delivery of care we provide each and every day to Houston's global community. Baylor College of Medicine's global legacy is built upon both these activities and efforts and endeavors that occur within our college's walls, but also the achievements of the college's graduates all across the world. I am both honored and humbled that our keynote speaker for the inaugural Center for Globalization Distinguished Lecture is a graduate of our great institution. Dr. José Esparza is the Senior Advisor for Vaccines at the Bill Melinda Gates Foundation. Dr. Esparza received his medical degree in 1968 from the University of Zulia in his home country of Venezuela, and his doctorate in virology and cell biology here at Baylor College of Medicine in 1974. He returned to Venezuela from 1974 to 1986 to the Venezuelan Institute of Scientific Research in Caracas, where he became professor of virology, chief of the Laboratory of Biology of Viruses, and chair of the Center of Microbiology and Cell Biology. He also served as a visiting professor at Duke University during this time. Dr. Esparza is a globally recognized expert in the field of human virology. From 1986 to 1995, Dr. Esparza was with the World Health Organization in Geneva, where he became a chief of the Biomedical Research Unit of the WHO Global Program on AIDS. In 1996, he joined the United Nations Program on HIV/AIDS and was the coordinator of the joint WHO-UN-AIDS HIV Vaccine Initiative. He became a leader in the field of HIV vaccines, promoting and facilitating HIV trials in developing countries. Dr. Esparza joined the Bill and Melinda Gates Foundation in 2004, where he established and leads the Global HIV Vaccine Enterprise, an initiative to accelerate the search for an HIV vaccine. I'm also excited to announce that Dr. Esparza just received the Congressional Medal of Merit this week. Very glad to hear that. And his distinguished lecture today is titled Harnessing Science to Solve Global Health Problems. Please join me in giving a warm welcome to Dr. José Esparza.
So, good afternoon. It's great to be back in Houston. We came for the first time to Houston back in 1970. I came with my wife. We're sitting there, and this was our honeymoon. We had married 1 week before, and then our honeymoon was to come to graduate school here. So, and I'm still married with the same woman. So it's a real honor to give this inaugural lecture of the Center for Globalization. For the last 25 years, I've been involved in a number of activities to promote global health. So I really want to congratulate the Baylor College of Medicine for this initiative, and I pledge my support to the college and to Bob in particular in their effort in the future. So I want to thank Paul Krugman, the president of the college, Peter Hotes for this invitation, who was concocted 2 or 3 months ago when he was visiting us in Seattle. And I want to recognize Jan de Boutel and Mary Estes, my former colleagues and professors 40 years ago, and still strong, and to Bobby Kapur, of course, and Lona, who has been wonderful making the connections for me to come here, and to many others in this room. And this time, I would like to discuss informally some aspect of global health. And I didn't prepare in purpose a formal presentation, just some ideas that I want to share with you to stimulate thinking on how to move forward in your program of globalization. So this is the outline of my presentation. First, I will tell you what I've been doing since my Baylor days, although Bobby already revealed my secret. Then I share with you some concepts about global health, what it means, what is the meaning of global health. To tell them some of the activities of the Bill Melinda Gates Foundation and what we're doing to harness science to solve global health problems. As Bobby said, I got my medical degree in Venezuela back in 1968. And I started my training in virology in Venezuela. So I decided to come to the US, and I did some research. And I found that the best place to learn virology was here, was in Baylor. So I came to Baylor in 1970 and 1974. I got my PhD, and I was the first graduate student of Priscilla Schaefer, who passed away a couple of years ago. And Priscilla was a wonderful mentor, and at that time, I did my work on the genetics of the herpes virus type 2, because we thought at the time that this virus was the etiological agent of cervical cancer. And we were wrong. It's human papillomavirus. But I am happy that today we have a preventive vaccine that is actually already having a major health impact in developing countries. So I went back to Venezuela, where I became a practicing virologist. I actually worked on the bench from 1974 to 1986 at the Venezuelan Institute of Scientific Research. And at that time, I was working with rotaviruses. And I worked with rotaviruses. Rotaviruses were discovered in 1973 as the cause, as a potential cause of gastroenteritis, of infantile diarrhea. And being in Venezuela, I say I have to work in a virus that is relevant for my country, for developing countries. But the other reason I decided to work on rotavirus was that I thought that this is a virus that the Americans will not work with. I mean, this is a virus from developing countries. I will not have competition. Well, I was wrong. But I have like 2 or 3 years where I could do some work and advance knowledge in the field. And again, I'm very happy that today we have vaccines against rotaviruses that are considerably reducing morbidity and mortality by rotaviruses. I spent 2 years at Duke, I worked with Bill Joklik in reoviruses, and we were actually at the same time in Duke. So Duke is my second American house, of course. In 1986, I moved to Geneva in Switzerland to work with the World Health Organization and with UNAIDS in Geneva. And there's a story that not many people know. I went to Geneva to work on viruses with epidemic potential. So I did work on yellow fever, hemorrhagic diseases. But in 1974, WHO decided to launch an AIDS program because we perceived that this was going to be a major health problem, global health problem. And WHO hired Jonathan Mann to lead the program. And Jonathan one day called me to his office and said, Jose, I heard that you are an expert on retroviruses. You know, Jonathan didn't know the difference between rotavirus and retroviruses. And I say, well, geez, a virus is a virus. Yes, I am an expert on that, and that's how I end up working in a retrovirus. And I focused for many years on the development of HIV vaccines. Since 2004, I joined the Bill Melinda Gates Foundation in Seattle, where I continue working with HIV vaccines, at least for the last 7 years. But today, I don't want to talk about HIV vaccines. I love to talk about HIV vaccines, especially because 3 years ago, we learned the result from the Thai trial RB144, a trial that showed us that it is possible to develop a preventive vaccines against HIV. And today, we may even have some hints of what is the immune correlated protection of HIV. But I don't want to use this opportunity to discuss that, but to actually to have a broader discussion on global health. So I already say why I came to Baylor. And I came to Baylor in 1972 because of this remarkable man that I don't know how many of you recognize, but it's Joe Melnick. And his wife, Matilda. And we just had lunch with Matilda today. A few years ago, in an interview that I had with Lancet, they asked me who was the person who influenced you the most. And of course, I have to say that was Joe Melnick. After I finished my medical school in Venezuela, and as I said, I wanted to be a virologist, and this was the place to come. And at that time was the best place, and today is the best place to learn virology. And I learned that your president, Paul, actually is a HIV virologist in disguise. He pretends to be a nephrologist, but in fact, he's a virologist in the heart. So those 4 years or 5 years in Baylor were memorable, not only because I learned a lot, I mean, they marked my career for the rest of my life, but also we have the best memories of living here. Actually, I was mentioned to Janet this morning that the Department of Virology and John Melnick and Matilda, they were not only mentors and professors, but they basically were part of their extended family. They adopted us. They adopted the students as their extended family. And I didn't come back to Houston. I don't visit Houston very often. But back in 2007, that was 5 years ago, we had a reunion of virology, where we invited virology trainees from the 1960s. I think that we have lost those from the 1960s already. But it was a memorable event, and this photograph is from that time, from 2007, with Matilda and my former mentor, Priscilla Schaefer, who passed away in 2009. So, but let's move now to some comment about global health. Unless I prefer to do that. Yes. Generally speaking, global health is the health of populations in a global context. But the concept is very complex. And is described in this slide that I borrowed from Mike Merson, who is the director of the Duke Global Health Institute, and he used to be my boss in WHO. This slide shows the evolution of the concept of global health. in relation to changing political aspects and economy. And I know that some people in this room may disagree with this interpretation, but it's one that is useful to trace the evolution of the concept. This slide shows clear eras in international health defined by historical transformations that have shaped new challenges and also new opportunities. So the end of the European colonialism in the 1960s changed the landscape on the field. So from tropical medicine, we start talking about international health. And Peter Hotez has actually written very thoughtful papers describing the origins of the Institute of Tropical Medicine in different parts of the world, and he used that analysis to propose the creation of a national School of Tropical Medicine here at Baylor. But we actually, in general, globally, we changed the terminology from tropical medicine, which was a colonial terminology, to international health. But the end of the Cold War in the 1990s brought a new context to the concept, with decentralization, with the participation of non-government actors, etc. And then we adopted the new label of global health. And that's where most people are today. And the efforts today in global health are focused mostly on categorical programs for diseases like AIDS, like TB, like malaria. And already those programs are paying in terms of life saved. But there are areas that still remain to be dealt with, particularly infant and maternal mortality. But we ask ourselves if we are moving to a new concept of global health, something that Mike Merson, in fact, this slide came from the Rockefeller Foundation, called World Health, a new world health, that may require new partnerships and more involvement and accountability of developing countries. So it's not about the developing countries, the developed institutions in developed countries going to developing countries to do good, but actually a partnership with developing countries. And there is a financial reason for this. In the last 10 years, and Peter probably can correct my numbers, funding for international health activities increased significantly. In the year 2000, approximately $8 billion were invested globally, mostly from the United States, for global health activities. And I had the number for 2008. And in 2008 was 28 billion, from 8 to 28. And I can tell you, it's not going to grow much more. So we are reaching a plateau. And we cannot expect that future global health activities will depend on the generosity of the developed countries. We have to build new partnerships with developing countries, of course including BRICS countries, but also the recipient countries. So the concept of new world health is something that we have to consider when planning future activities. Now, global health is not only good intentions or an opportunity to do interesting international research or even an opportunity to travel to exotic countries. Global health is about international social justice. And one approach to frame our international work was proposed in June 2005 by 193 member states of the United Nations. And some of you may be familiar with the Millennium Development Goals that are listed here in the slide. And this is not the only way to think about global health, but it's a good framework. But I agree there may be other frameworks. And those 8 Millennium Development Goals have specific metrics and specific actions. And I will read it. Goal number 1 is to eradicate extreme poverty. By the way, the goal was to achieve some progress by the year 2015, which is only a few years from now. So eradicate extreme poverty. The second goal is achieve universal primary education. The third goal is to promote gender equality and empower women. 4 is reduce child mortality. 5th is improve maternal health. 6 is combat HIV/AIDS, malaria, and other diseases. And Peter has written extensively about the other diseases that were not named in these goals, to ensure environmental sustainability and to develop a global partnership for development. What is important is that the international community held itself accountable to achieving these goals. This is not only good intentions, but there was a metric developed to assess the progress in these goals. And I highlighted here goals number 4, 5, and 6 that are more relevant to the work that we do. And let's take a look at the goal number 4, which is to reduce child mortality before the age of 5 by 2/3, from the 1990 level of 90 in 1,000 to 30 in 1,000 in 2015. That was the goal. That was the metrics that the international community proposed. This is the metric that we are accountable to achieve. So every day, 29,000 children under 5 die. It's 21 each minute. And more than 70% of the 10 million deaths in children are attributable to 6 causes: diarrhea, malaria, neonatal infection, pneumonia, preterm delivery, or lack of oxygen at birth. The majority of those deaths are occurring in the developing world. So the question is, where are we today? 3 years from the 2015 endpoint. So globally, the mortality rate for children under 5 has declined by 1/3, not 2/3, which is our goal. So we have gone from 90 to 60 per 1,000. In sub-Saharan Africa, it has come down from 180 to 120. And in developed countries, came down from 15 to 7. So progress has been made, but major disparities still persist, particularly between developed and developing countries. And we believe that a key strategy to achieve the goal is through the use of vaccines. Vaccines are one of the major priorities of Bill Gates, so it's one of the major priorities of the foundation. And I have commented today that Bill Gates liked vaccines because for him, vaccines are similar to software. Both of them are very difficult to develop, but once they are developed, they are very cost efficient. And we like vaccines because vaccines save lives. Approximately 2.5 million lives are saved every year because of vaccines. And we will save many more lives with the vaccines that we'll be developing in the near future. But let's talk a bit about one remarkable success, which is smallpox eradication. And smallpox eradication is not the only success in vaccinology. Of course, polio has been eliminated from different regions in the Americas, and today there are only 3 countries with endemic polio, which is Nigeria, Afghanistan, and Pakistan. And in February of this year, we actually celebrated 1 year without polio cases in India. That was the country with the larger number of cases of polio. So we believe that eradication of polio is possible. And our goal is to eradicate polio by the year 2015 and to certify eradication by the year 2020. Now, polio has to be very close to Baylor, because one of the leaders in the early work on polio vaccines was precisely Joe Melnick, and we can discuss that later on. So, but measles has also been eradicated in North and South America, as well as rubella. Coming back to smallpox, for centuries, this disease was the most terrible of all the minister of death. That's what Thomas Macaulay, historian, British historian, referred to, mentioned in relation to smallpox. And vaccination was developed, as you all know, by Edward Jenner in 1776. 14th of May of 1776, Jenner vaccinated the first person in history that has been vaccinated. And I am in a campaign to declare that the World Vaccine Day, 14th of May. Now, in 1967, the World Health Organization initiated the smallpox global eradication campaign in 1967. And the last case of naturally occurring smallpox occurred 10 years later in October 1977. So I have a question for you, but you don't have to answer vocally. But how many cases you think of a smallpox occurred in 1967, the year when the global eradication campaign started? And I gave you 3 choices. And I asked the question to Bill Gates, and he was wrong. He will never. Then he agreed. He argued with me that he was not wrong because of the mathematics and so on. But look at these numbers. How many cases of smallpox occurred in 1967, which is not long ago. I mean, many of you in this room are very young, but I was already almost a medical doctor at the time. Well, the answer actually were between 10 and 15 million cases of smallpox in 1967. Yes. And 2.6 million deaths every year, which is approximately the same number of deaths that we have every year caused by HIV. And the smallpox was prevalent in 31 countries. And people forgot about that. And that's why I say that the power of vaccines is such that they not only eliminate the disease, but even our memory of the disease. So that's the power of vaccines. And in 10 years, I hope we don't even remember how many cases of polio used to occur, in the early 2000s or 2010. Now, the second vaccine for human use actually was developed almost 100 years later. It was rabies by Pasteur in 1885. So it's 90 years between smallpox and rabies. And then at that time, that was the years where the germ theory disease was proved by work of Pasteur and Robert Koch. And Vibrio cholera was identified in 1883. There was a race to develop a vaccine. A vaccine was developed, and a cholera vaccine actually was compulsory in many countries at the beginning of the 20th century. Today, we had a very interesting conversation about subunit vaccines using genetically engineered Maria Elena vaccines. But the first subunit vaccine actually was developed in 1923 by Gaston Ramon in France. And it was the anti-diphtheria toxin. So, and then other vaccines were developed in the years that came. And vaccines actually have eliminated many diseases in the United States, and this is the list. It's an impressive accomplishment of vaccines in the United States, but not in many developing countries. So we are living a time of vaccine inequity. The benefits of vaccines that has been realized in the United States and other industrialized countries have not reached many developing countries where children and people still die of the disease. So this slide is to show the vaccines that we had for routine immunization in 1990. And there were 8 vaccines. By 2011, we have 16 vaccines. Actually, 25 are licensed, which are the vaccines that have been used in routine immunization. And I was asking Bobby today if the advances in medicine and the new vaccines that we are developing will help decreasing the gap between rich and poor, or the opposite, will increase the inequities between the rich and the poor. And our goal as member of the global community is to ensure that the advances in medicine and the new vaccines that we'll develop in the next few years will actually benefit not only people in industrialized countries, but also benefit people in developing countries. And this takes me to a discussion of the Gates Foundation. And I don't like those slides, okay. So, more than 10 years ago, Bill and Melinda read about the million of children dying every year in developing countries from diseases that don't kill anymore in industrialized countries. But one disease in particular caught the attention of Bill and Melinda. And that disease was killing almost, actually 800,000 children every year. And that's diarrhea caused by rotaviruses. And he asked, I mean, this must be a typo. I mean, I cannot believe, he said, that there is a killer out there named rotavirus. I never heard of it. And in fact, the realization that there was a disease that was killing so many people, and that he could do something about that, led him to basically to create the Gates Foundation. And I have to say, but you know, of course, that the work of Mary Estes here, my friend of many years, has been critical in the fight against this killer. And today we have a vaccine against rotavirus that is saving millions of lives. So rotavirus is at the heart of the beginning of the Gates Foundation. Now, in 2006, Warren Buffett surprised Bill and Melinda, but all of us, with a pledge that many of his shares in Berkshire Hathaway will be given to the foundation, actually doubling the foundation annual grant-making and potential impact. In 2008, Bill made his transition from Microsoft to the Gates Foundation, joining Melinda full-time at the foundation. Bill and Melinda started the foundation because they believe that all lives, no matter where they are being lived, have equal value. So, let me see this here. I hate those slides. The way how, let me explain the way how we do grant making, because it's complex and it's very important for us to understand how do we do our work. Our grant making involves 4 key steps. We develop a strategy, then we make grants, then we measure progress and adjust the strategy. But before we make any grant, we try to figure out which problems cause the most harm and receive the least attention. In this analysis, we consider costs, risks, viability, and impact. We work during this time that can extend over a year with external experts to develop a strategy, a budget to identify outcomes, and to create a plan to measure results. And when we have the plan, we discuss this with our CEO and then with Bill and Melinda and hope to receive their agreement. Once they agree with the strategy, and we have 24 strategies in the Gates Foundation for different diseases. We have a strategy for respiratory disease, and a strategy for HIV, and a strategy for enteric diseases, for education, etc. Each strategy has to be approved personally by Bill and Melinda. And once they approve the strategy, they provide the envelope of funding that we will use for the next 5 years. So after receiving approval, we look for partners and grantees who are best qualified to implement that strategy. And in most cases, we make grants, and we establish formal agreements that specify outcomes, milestones. Many of our grants go to large intermediate partners, particularly what we call the PDPs, the Product Development Partnerships, organizations that help us implement our activities. After we make a grant, we require our grantee to measure and report on their work. at least once a year. We also assess progress towards our grants every year. And every 2 years, we take stock of our overall strategy and we make the necessary adjustments. Following that approach, we arrive at 3 major areas of focus. It's global health, and actually our global health activities represent about 50% of our investment. We have activities in global development, including water and sanitation, microfinance, and education. And 1/4 of our investment is made in what we call the domestic U.S. programs. Now, this has been revised, and we are currently redesigning our structure to make a better coordination between the global health activities and the global development activities. So the global health is actually becoming our research and development component. We develop the new technologies, the new interventions that then are delivered through our global development program. But this is what we are until now. And this is how we distribute funds. About $1.5 million. This is 2010. 2011 is probably a bit higher. 1.5 billion were invested in our global health programs. And then you can see in the slide how we funded other activities. So major area of activities actually in global health. Let me talk a bit about our global health program then. Now, the problem defines our mission. 2/3 of the 6 billion people who live in the world live in the developing world. 2/3 live in the developing world. And more than 1 in 6 live on less than $1 per day. So when I hear plans to conduct international activities and global health programs, I remind them that in many developing countries, they don't have the resources to do what we think should be done. I was in a recent meeting organized by Harold Varmus in the National Cancer Institute, when the group was discussing international activities of the National Cancer Institute. And Jeffrey Sachs actually gave a plenary to Skynet, and he reminded us that in most African countries, the public expenditure in health is between $10 and $30 a year per person. This contrasts with $8,000 a year in the United States. So we need to think about that when we actually plan international activities. So as I say, millions of people die unnecessarily each year from diseases. 4 million infants die each year, a rate of 450 deaths per hour, and half of those deaths occur by infections. That's why infectious diseases are one of our priorities. And the developing world accounts for 99% of the annual total death due to AIDS, TB, and malaria. So our mission is to ensure the life-saving advances in health are developed and shared with those who need them the most. So some of you asked me this morning how we prioritize our work. And we have 4 filters. We choose the conditions with the greatest burden. And that's why we focus on infectious diseases, nutrition, and reproductive, maternal, and neonatal health. We also work in areas in diseases and conditions where the imbalance is the widest. Problems that in a disproportionate way affect developing countries, poor countries. That's why we don't work in cancer, we don't work on neurological disease. We focus infectious diseases in general. We also work in areas that need attention. There is a gap in attention. Areas that are not receiving adequate resources of attention. And we have a long-term vision. We focus on prevention, not in treatment, and we invest in long-term breakthroughs. And this is more detail how we invest in global health. And I actually try to indicate here that more than 60% of our funding goes to infectious diseases, and with a very heavy component on vaccine interventions, which are diseases in the red boxes. We are technologically oriented. We recognize that advances in science and technology must be harnessed to save life in developing countries, and that vaccines and drugs can defeat many of the world's deadly diseases. We work to develop and deliver low-cost interventions to prevent and treat diarrhea-related diseases. We provide families access to high-quality, voluntary family planning services and contraceptives. We aim to reduce the burden of HIV by accelerating the development of vaccines and other preventive technologies and demonstrating effective and efficient models for delivering HIV prevention and treatment. And we continue to make headways against the goal of a malaria eradication. We advance the use of practical tools and strategies to reduce the number of mothers and newborns who die during and immediately after childbirth. We work to reduce the burden of neglected diseases such as guinea worm and river blindness. And we have funded Peter for a vaccine against hookworm. We focus on preventing malnutrition in young children to ensure proper physical and cognitive growth and improve disease resistance. And by improving access to affordable vaccines, we reduce the number of pneumonia cases among children in developing countries. With our partners, as I mentioned before, we are exploring every avenue to eradicate polio by the year 2015. I mean, I have to remind you that we have an effective vaccine against polio that was developed in 1955. So we have the tools. And for Bill Gates, eradication of polio is a proof of concept that if we have the tool, we can eradicate the disease. So it's not only the goal of eradicating polio, but also to prove the power of science and the promises for the vaccines. And we help promote the strategies to prevent and reduce tobacco use and to curb tobacco-related diseases in developing countries. We are helping to develop and introduce new ways to prevent, diagnose, and treat tuberculosis. And we focus on the discovery, development, and delivery of vaccines, which is, as you know, the most cost-effective and efficient way to prevent diseases. Vaccines present the best opportunity to save the most lives in developing countries, especially those of children. And that's why by 2015, we will immunize 90% of children against diseases like measles, pneumococcal pneumonia, and rotavirus. And we invest heavily in vaccines in the hope that one day they can be used to prevent HIV, malaria, and tuberculosis, to wipe out polio, and to help save children from dying of diarrhea and pneumonia. This graph gives us encouragement, but also challenges us. It shows the average number of deaths worldwide each year among children under 5, beginning in 1960 and projected through 2025. The global mortality rate for children less than 5 years has declined by more than half over the past 50 years, from 20 million in 1960. And we believe that with the help of vaccines, old and new, we can reduce that rate to 5 million by 2015. And I want to finish with some comments that Bill Gates made during the World Health Assembly in May 2005. He said there is not bigger test for humanity than the crisis of global health. Solving it will require the full commitment of our hearts and minds, and we need both, he said. Without compassion, we won't do anything. Without science, we can't do anything. And he said, so far, we have not applied all we have of either. Thank you very much for your attention.
Thank you, Dr. Esparza, for that wonderful lecture. And now I'd like to invite a few of our distinguished faculty in the area of vaccines and virology to please come and join you on a panel discussion. I'd like to invite Dr. Janet Patel, Distinguished Service Professor and Chair of the Department of Molecular Virology and Microbiology. Dr. Mary Estes, Professor of Molecular Virology and Microbiology. And Dr. Peter Hotez, our founding Dean of the National School of Tropical Medicine and President of the Sabin Vaccine Institute. Now I'm going to start with a couple of questions for the panel, and then we have microphones here. We really would like to engage the audience for a few questions also. So, Dr. Esparza, there's been a lot of interesting discussion and debate about the recent trials on HIV vaccine trials in Thailand. The candidate vaccine was weekly protective, about 31% efficacy. So one of the questions we've had is there a place for a weekly protective vaccine against a serious epidemic when there's nothing else better available?
Well, I mean, the way to confront the AIDS epidemic is with every weapon we have. There is not magic bullet, and a vaccine will not be a magic bullet. So we are talking more about the use of treatment, behavioral intervention, etc. It's a combination prevention, the same way how combination therapy has been so effective in the treatment. Combination prevention is the way to go. Now, that trial that you referred to was the trial that was concluded 3 years ago in 2009 in Thailand and showed 31.2% efficacy. I have to say that vaccine cannot be licensed, and that vaccine cannot be used at that level of efficacy in public health programs. But 2 weeks ago, data was published on a potential immune correlated protection. So we think we may know the immune response that vaccine induced that protected against infection. Now our challenge is to build on that information and to improve that immune response that we know correlates with protection. So the current effort is to develop a next generation of an HIV vaccine that induce better levels of that type of immune response and to achieve at least 60, maybe 70% efficacy.
Please, Peter.
So I basically agree with Jose. I mean, I think we have to change our expectations about how a vaccine works for this newer generation of vaccines. In some ways, we already finished the easy ones. Polio, measles, where you're basically replicating the effect of the virus through attenuation, where you're getting more than 90% protection. We're now faced with much more formidable targets. Tuberculosis, malaria. I mean, the new RTSS malaria vaccine is providing, about 50% reduction in child mortality. And I think we have to be willing to accept targets that go way below 90% protection, way below 90% reduction in deaths, recognizing now that some of these newer vaccines may not be used alone, so that our strategy for preventing measles is basically giving the measles vaccine. Our strategy for preventing malaria or hookworm or tuberculosis is not going to be just giving the vaccine. It's going to be giving the vaccine together with anti-malarials and bed nets, and we have to think about using vaccines in a more integrated framework than we have in the past. So it's a different paradigm that we have to start thinking about.
Can I mention something like that? I mean, Peter, you mentioned that most vaccines that we have today basically try to replicate the natural immune response to pathogens, to the infection of pathogens. That's how we develop it.
In some cases, yeah.
But I believe that the new paradigm is to develop what I refer to as unnatural immune responses that are not elicited easily by the infection, but that may be more effective. I give you one example. In influenza, the natural immune response is against some area of the hemagglutinin of influenza, but that's the area where the virus rapidly escapes. But we know that there are epitopes that are conserved among different strains of flu that can actually provide a more cross-strain protection. So I believe that the new paradigm of vaccine development is actually to develop a natural immune response.
Very good. Thank you very much. Dr. Estes, quick question. The immunogenicity of oral enteric vaccines, and a lot of your work has been in rotavirus and now on Norwalk virus, in children primarily in developing countries, is clearly reduced, especially like in poliovirus and rotavirus being two examples. Should resources be allocated to understanding why this occurs and for developing alternative modes of delivery for efficient immunization with enteric vaccines?
So this is referring to the fact, for example, the oral polio vaccine, which now does work. It works very well in the United States. In India, a child may need 10, 15, 20 doses of that vaccine to become protected. And we don't fully understand why. We can go back to Dr. Melnick. When I first came here, he used to talk about the problems that they were having getting the polio vaccine to work in places like Israel or even the West Bank. It worked actually in Israel, it didn't work in the West Bank. And he at that time was trying to study this. One of his hypotheses was that it was the fact that many of the children in these environments are infected with many other enteric pathogens. They might have another virus infection. In fact, if you took samples from India and took a sample and tried to grow a virus, you could grow that virus, identify it, get rid of that virus, you would grow another virus. In some of those samples, you could grow 10 or 12 viruses. So many of these children clearly had many infections. We're seeing now the same thing with the rotavirus oral vaccine. It's very, very effective here, and in India and other developing countries, it's maybe 50% efficacious. And I think it really is important to try to understand exactly why. We have other ideas. Is it because children are malnourished that they're not responding? Or are there other bacteria that perhaps are interfering? I think it's very important to try to understand it. I think it's important. I think we can understand this now with the resources that we have available to us.
In fact, we have a young MD PhD graduate from Baylor who is now a pediatric resident here. I don't know if I see him in the audience.
Right
Jeff Pratis.
Just right there.
Oh, there he is. Who's exploring the metabolome and looking at metabolomics as a basis to understand why it is that we get immune responses in either malnourished laboratory animals or don't, and the same can be applied to translational research in people. So I think through a lot of the new omics technology, we have a lot of exciting ways to start approaching problems like that.
Yeah, actually nothing is new in science. As you know, we all refine the old knowledge. There is a paper by Sabin and Ramos Alvarez in American Journal of Public Health, published in 1960. And he actually showed that in Toluca, in Mexico, the oral polio vaccine was not immunogenic because of the other intercurrent infections. But we prefer not to pay too much attention to that. But the reality is that oral vaccination with the same vaccine actually basically control polio in the world. Now, we believe that we may need to shift, in the case of polio, to inactivated, new formulation of inactivated vaccine for the end game. Yeah. But, yes, I mean, Dr. Klotman referred to something that we call treatment as prevention, or treatment for prevention, which is it was an area that was neglected until very recently. And we have to understand that in an acute infection like polio, probably the only way to intervene is to protect the healthy individual from exposure to the virus. But in a chronic infection, like HIV, we have another opportunity to intervene, is to make that person less infectious to others. And that was neglected for many years until a colleague of mine, actually from Argentina, Julio Montaner, proposed that a few years ago, treatment for prevention, and he conducted the right experiments in Vancouver, and he showed that treatment of people with HIV not only benefited those individuals, but actually reduced the circulation of virus in the community. Now, today, and there is a trial done by NIH, the HBTN 025, I believe is the name of the trial, that show very clearly that treating in discordant couples, treating the infected couple will significantly decrease transmission to the non-infected partner. So that's science. Now, how we translate science into policy and how we translate policy into implementation, that's the challenge. So people are now making the calculations to see what is cost-effective. What I can tell you is the following. We cannot do HIV vaccine trials in the future unless we provide to the trial participants antiviral drugs if they are in this condition. So doing vaccine trials, not only for HIV, for other diseases, is becoming very difficult in the future. So we have to be very smart and use modern technologies, system biology, whatever. We have to use modern science to be able to continue developing new vaccines, yes. But this is actually, I'm very happy that we don't have to rely only on an HIV vaccine, that there are other interventions. Yeah, that's right.
Well, that includes the new finding of a microbicide that contains an HIV drug that seems to be effective.
Correct. I think that's a question to Peter.
I guess I'm having a little trouble understanding the question. The question is, what are the consequences?
Well, we're trying to quantify where the greater benefit is.
Right. Well,
whereas with respect to new and predictive diseases, we don't have the quantifiable data on what they may be 10 years from now or 5 years from now.
Well, I'll tell you, one of the important collateral benefits that we are now beginning to realize from reducing the burden of tropical diseases is, and it's the hardest thing to quantify, but I think we're having some success now, is the economic benefit. So one of the observations that we've made and others is that a lot of these neglected tropical diseases not only occur in the setting of poverty, but they're actually a stealth cause of poverty. And so we have this, now we're starting to see this unprecedented collaboration between tropical medicine experts and people from the business and economics community to really get our arms around that. So for instance, we collaborated with an economics colleague at the University of Chicago, a guy named Hoyt Bleakley, who came up with this interesting number that chronic hookworm infection in childhood reduces your future wage earning by 40%. So that it's hookworm that's really trapping the bottom billion in poverty. So therefore, you would think if you could vaccinate against hookworm, you would not only have an impact on improving health, but also lifting people out of poverty. So we coined the term anti-poverty vaccines, which is something that is going to be a very important impact, we think, for a lot of these vaccines. India loses $1 billion a year in economic losses from lymphatic filariasis because people are too sick to go to work in the fields every day. And this is especially important for infectious diseases which are debilitating but not necessarily killers. So mortality, so mortality is just one very small part of the bigger piece in terms of the impact of a lot of these infections and a lot of these diseases. And so
we have the economic impact of diseases and different interventions. So it's part of the equation, yes.
One of the real fascinating studies was conducted by a colleague of ours, Jeffrey Sachs, who's at the heads the Earth Institute, where he can very nicely trace the dramatic improvement in economic growth in Spain, Italy, and Greece in the years following World War II to the eradication of malaria in those countries, and showing that there was real cause and effect between getting rid of malaria and showing this big improvement. And of course, now what's happened in Greece can't be because of recurrence of malaria. If only we're that simple, but it isn't.
I mean, compliance in HIV is a major problem. Compliance in treatment for prevention, pre-exposure prophylaxis. Now, we have solved the scientific problem. We know that if the patient, the volunteer is compliant, the intervention works. But when it doesn't work, it's in many cases because of lack of compliance. So I totally agree with you that an approach that will require less contact between the patient and the healthcare provider is the better. And in fact, this is one of the criteria we use to develop new interventions, for instance, in microbicides. One that requires daily administration is a problem, will be a problem of compliance. But if we can actually develop a system of a slow release that requires only an interaction between the patient and the healthcare system once a month or every 6 months, that will be the way to go. So it's very much a part of our strategy. And we understand the limitations of that compliance provides. Yeah.
Very good. Thank you very much. I want to thank our panel for participating this afternoon, and thank you, Dr. Esparza, for a wonderful talk. Thank you very much. I'd like to...
This is for the distinguished lectureship today, the first inaugural one for our global our efforts in globalization.
Una más.
All right.
Okay.
Thank you. Thanks.